Hi there, everyone. Thanks for joining in. We'll give it a few more minutes for a few more people to filter through, then we'll get started. All right, good evening, everyone. We'll get started in a second, but thank you all for joining. Today, we're going to be talking about the critical analysis of randomized controlled trials. And just as a disclaimer to start off, this is not going to be me teaching you about the different parts and pieces of a randomized controlled trial, because I'm going to assume that a lot of you know the basics of it anyways. So it's going to be about actually seeing why the different parts are relevant and how to actually analyze the different bits and see whether they're good or bad, or whether you should actually trust this study. Okay, so the whole so we've talked about the learning objectives. The whole point of this is because whoever's in healthcare, they're always going to see randomized control trials everywhere. That is how drugs get into the market and approved. So we must know if the randomized control trials are actually robust and good enough to give us the evidence we need to decide whether a certain intervention should be used for a certain condition. Um, and just another reminder, if you do have any questions, just post them in the chat, and there will be a Q&A section at the end where I'll go through all the questions. Or if you're having any trouble with anything, just put it in the chat. So as I like to do, for some of you who've been to one of my webinars before, and I see some familiar names in the audience, we'll start off with a little Mentimeter quiz to get an idea of how much knowledge everyone has on this topic. So I'm just going to share that screen, and I'll put the code in the chat as well. So the screen is up here. You should be able to see it. I'm also going to put the link, the code in the chat. Oh, the link, apparently. There you go. Links in the chat. I'll give it a couple of minutes for everyone to join in. I promise it's nothing too strenuous. This is going to be much less stressful than the last webinar I did on the analysis of lab-based research. Much more enjoyable and relevant to everyone, I think. So a couple more minutes and we'll get started. All right, actually, we've got a good number now. I'm going to hit start. All right, you have about 25 seconds in this one, I think, to read the question and the answer options. Yeah, I was generous. Ooh. So don't worry about getting things wrong right now, because these are things we will discuss in the duration of the webinar. But no, actually, they're not less reliable than parallel RCTs. So next up, everyone's here, and let's get started. Ooh. Just take your time. There's a lot of words. Ooh. Not the easiest one I gave you to start off with. That was a bit mean of me. I'm sorry about that. But yeah, we'll talk about p-values during the course of the webinar anyways. But yeah, it doesn't tell you about clinical significance. It tells you how significant the effect was. That doesn't always mean that your intervention is going to be effective clinically. I'm going to stop sharing this now, and let's go back to the actual presentation. There's a question saying, what is washout period? And we will be discussing that in the webinar, so don't worry, we will get there. Let me just share the other screen once again. Okay, so I've tried to be systematic about this. I've split the webinar into 3 parts, 3 areas of appraisal for a randomized control trial, and that starts off with study design, and then how the authors have actually analyzed the outcomes, and then a few other things which I couldn't come up with a better name for. So we're going to call it miscellaneous. Okay, so study design. A randomized controlled trial. Oh, I forgot to mention. I've taken extracts from an actual randomized controlled trial, so you will see little snippets at the bottom, and it's going to look like a lot of text. Don't read that. Just focus on what I'm saying and read the bullet points above if you must, because you don't need to read all the text at the bottom. I'm just going to explain the highlighted bits there. Okay, so all randomized controlled trials will have some sort of an inclusion and exclusion criteria. And what that tells you is, well, it's in the name, who's been included and who's been excluded from the study. And authors will have different reasons for including and excluding certain people, like contraindications of the drug. You wouldn't want to give an intervention to someone that's contraindicated to it. But the more people you exclude, the less generalizable your study becomes, because you're essentially testing your intervention on a smaller population group, or on a smaller sample group, I should say. So it's very important to look at these things, because some people that you exclude might actually make up a large proportion of the population that you want to treat. So if you're excluding them, then will the intervention you're testing actually be useful in a clinical scenario? It would be significantly diminished. So we can actually have a look at that in this example. We're going to use this study throughout, so you have some continuity there. A randomized controlled trial of liraglutide for adolescents with obesity. Now, I'm no expert on obesity or liraglutide, but it is a GLP-1 agonist. So it causes something called the incretin effect, which is implicated in obesity and type 2 diabetes. And so we'll look at the inclusion criteria first. History of failing to lose sufficient weight with lifestyle modification is one of the criteria that the participants must have met to be included in the study. Now, well, sociologically anyways, a lot of people with obesity just find it difficult to initiate those lifestyle modifications. So this randomized controlled trial wouldn't even be able to check on people in that population, people who haven't managed to initiate their lifestyle modification, because they have to have had a history of trying to improve to be able to join this study. So just by looking at that one line, we've already seen a bit of population that we can't generalize the results of this study to. And then if you look at the exclusion criteria, they included type 2 diabetics in this study, which I think is quite good, because the two do go hand in hand quite often. But they exclude people on other anti-diabetic treatments, anything other than metformin, which I don't know what proportion of type 2 diabetics are not on metformin or on some other sort of diabetic control. but they would all be excluded and the study results wouldn't apply to them. So that should have you thinking in your mind, okay, is this study actually relevant? Because if you're excluding all these people, who's left? Who are the results for? And that's what critical analysis is. Not just looking at things and seeing, well, it's trying to work out why they did that, but it's also trying to see what that does to their conclusions. So they might decide in the end, we haven't got there yet, but they might say liraglutide is amazing for adolescents with obesity, but they've excluded all these different people. So is it really that good? And that's what critical analysis is all about. So moving on from inclusion and exclusion criteria, we're going to go a bit onto the layout of how studies go. So we start off on the left-hand side. Let's look at the left-hand panel first. The classic parallel randomized controlled trial. I'm not going to explain it, but we will discuss some individual bits of it later on. A crossover trial is less common, so I will talk about a few of the bits of it right now. For example, someone asked about the washout period. It all depends. The washout period will make more sense when I explain how a crossover RCT works. Your study group is split into two groups. One gets the treatment A, like in the diagram. One gets treatment B. But after a certain amount of time on those treatments, they swap treatments. And there's a period of time in between the swap where they're on no treatment at all, just so that the effects of their first treatment wears out of their system, so the drug is no longer in their system. So a bit of analysis you can do here is, well, if the drug you're trying to test has a half-life of 5 days and your washout period is 2 days, by the time your patient group is on the second cycle of treatment, they'll still have drug A in their system. So are the results actually representative of drug B? No, they're not. Which is why you need to have an appropriate washout period. And that will involve some Googling, depending on the intervention they're doing. I don't know the half-life of liraglutide, but if I was trying to extract relevant results from them, I would look it up and have a look at exactly the washout period they used. Crossover studies. I hope that answered the previous question in the chat, by the way. Otherwise, we can discuss it further in the Q&A section. Another problem with crossover randomized controlled trials is they tend to be a lot longer because you have fewer people. So people tend to drop out of these studies because it's just hard to stick to the study protocol, especially if it's longer and depending on the intervention. There was a big crossover trial to do a diet to test something called the DASH diet, and the effect of salt intake on blood pressure, I think. And that study lasted, I think, over a year with hundreds of people who had very specifically provided diets by chefs, and they could only eat that. And I don't know how happy you'd be eating saltless food for 3 months in a row with no option to have your own food. So I think you can appreciate why people might not follow these things perfectly or might drop out of the study, because it's difficult, even if you're getting paid. So moving on from design then. Randomization. Randomization, essentially, in simple terms, is that every participant should have an equal chance or probability of being assigned to the treatment group or the placebo group. And it's done so that you get balanced characteristics in both the treatment and the placebo groups, so that you can say your result at the end was actually due to your intervention and not due to a difference in the baseline characteristics of each group. So let's say let's look at this example. If you can read that little table there, or a few of the things on the table there, you'll see that this study has accounted for a lot of important factors that might play a role in obesity. They have the BMI, waist-hip ratio, glycated hemoglobin, fasting blood glucose, blood pressure, cholesterol, triglycerides, even quality of life. So they've produced a treatment group and a placebo group with balanced characteristics for all those things. And to me, that looks like most of the important confounders that might affect their results or that might influence obesity have been accounted for, and have been accounted for well, because the numbers look very similar in each of the groups, liraglutide and placebo. But some studies might miss important characteristics. For example, let's say I did this study, but I didn't randomize relative to blood pressure as well. Then there could be a possibility that my liraglutide group ends up with completely normal blood pressures, but the average blood pressure in my placebo group is something like 160 systolic. That difference in blood pressure between the two groups might make your results look funny or might make your results not realistic. So it's important to look through the table that every study should provide on randomization to see if they've missed anything that might be relevant to their the condition they're trying to intervene for. So it's really, that's how you would appraise a randomization, just by going through that and seeing if they've missed a certain characteristic that they should have randomized for. Okay, moving on from randomization, blinding. Again, I'm sure a lot of you understand what blinding is. I'm not going to go into what single and double blind is, but it's just to do with whether the participants or the assessors are blinded or both of them. And it prevents something called assessment bias, because the people who are running the trial obviously want to see their drug work or their intervention work. And if they know a patient has come to them and they're on the treatment, they might be a bit more favorable in measuring, for example, BMI or waist hip ratio in this study case. They might give them better lifestyle advice, or they might tell them to eat certain foods just to make it look like their drug is doing a bit better than the placebo, which is why it's essential that blinding is carried out. At best, it should be double blind. You can even have triple blind, where the people who are analyzing the data are also blinded. The more blinding you do, the better, essentially, to prevent something called assessment bias that we've just talked about. That was quite a quick one. And you can see in this example that in this study, it was a double-blind trial. Okay, moving on to the actual interventions. They may have something called a run-in period, which is a period of time where you start off the drug at low doses and maybe build up to the right dose, or you start with some other form of therapy to then get patients ready or participants ready. And that period isn't usually analyzed in the study. But things to look at when you're thinking about the intervention that was used in the randomized controlled trial is what dose was used. Is that similar to other studies, other studies and practice? Is it way higher? Is it way lower? Why is it higher? Why is it lower? Could that have had any effect? If you're giving a drug at a massive dose, you might want to think about side effects as well. Has it caused any side effects? Is it safe at that level? You might want to go back and look at the phase 2 and phase 1 trials for that drug, if it's a new drug. Was enough time provided to see an effect? Obesity is a chronic condition, so the change that will be accrued will happen over a long period of time. So you want to see how long the study was carried out for. It's also a type of condition which relapses once you get off treatment. It's notorious for that. So you want to see how long they were followed up for and what sort of results that follow-up period provided when they were not on any treatment. And is it so long that people won't comply or people might drop out? And I was hinting at that earlier. Attrition is an important thing in longer studies, and we'll discuss that more later anyways. So if we look at our live example, this study had a 12-week run-in period where participants were provided lifestyle therapy to start off with. Not much you can analyze there. I find it interesting, though, that earlier they only included people who had already attempted lifestyle therapy. And then they also had this run-in period with lifestyle therapy, which may be just to get everyone on the same level of what type of lifestyle therapy they'd received, something like that, possibly. I can't really comment on the dose of liraglutide. I'll leave that up to you guys to Google later on. And the study was carried out for 56 weeks, so about 13 months there, which is quite a long period of time. And you should ideally see a change in BMI or whatever their outcomes were over that period of time. And they did indeed have a follow-up period for about 6 months. Is that enough of a follow-up period? It depends. Obesity could be a lifelong condition. It all depends on the results. And we will have a look at that later on. So it's just stuff you need to be thinking about while reading through and working out whether this is a good drug for obesity and whether it has to be a lifelong drug or a short-term treatment. Outcomes. So you have the primary and secondary outcomes. And the important thing to note here is, do the outcomes actually answer the question? They want to look at obesity. So have they measured obesity markers? It's quite interesting in this study. If you read some of the red boxes I've highlighted in the study, their primary endpoint, which is the main focus of the study, was the change in baseline BMI standard deviation score. Now, I don't expect, I hadn't heard of this before, so I'm not sure if you have, but what the BMI standard deviation score is just how different a participant's BMI is from the mean BMI of their population. So they've essentially, I didn't know why they did this at the start, but I realized they've done this study over 5 different locations, 5 different countries. So it's important that they do the study relative to the population BMI of the country that the study was carried out in. And what they're assuming is that the BMI standard deviation is very high at the start because you've got a lot of obese people compared to the mean BMI, which they're assuming is normal. And then they would expect to see that come closer to the mean BMI. What this doesn't account for is whether that population mean BMI is actually healthy. For example, this is a made-up example. The mean BMI could be something like 55. And your BMI could start getting closer to that, so the standard deviation score could decrease, but that doesn't mean they're not obese, and it doesn't mean they're healthier. Okay, so it's important to think of these things and what the results are actually showing. Do they actually answer my question about whether this drug is good for obesity? In this case, luckily, their secondary outcomes were very, very detailed. They looked at change in the actual BMI number itself, body weight, waist-hip ratio, glucose metabolism. So all factors which are measures of the burden of obesity in a patient. And very importantly, I really look for this in studies. They looked at quality of life as a secondary outcome because not everything is about curing the obesity or treating the obesity. It's also about how the participants live later on. So I definitely look for that in all randomized controlled trials. And that's something you can critique about randomized controlled trials. You can say that, oh, fine, it improved BMI, but did that actually change a person's quality of life? Will it actually be relevant in reality? That's how I would approach something like this. And then you can also look at how often these things were measured, whether they were self-reported. Self-reported BMIs are notorious for being biased because people will just report them how they want to report them. I would not want to report a very high or very low BMI. But well, people are in the study, they've signed a waiver, so they might be more inclined to be honest, but it's best to take their word at caution. So next up. Okay, we're coming to outcome analysis, and I see there's 5 questions in the chat, so I'm just going to have a look at that first, just because we've got quite a few piling up. Okay, there's a few questions on parallel RCTs and clinical significance, which we'll talk about later, and a bit on my voice is breaking. If anyone else is having this problem, please do let me know. Unfortunately, this Medall is telling me that my network is at 100%, so I don't think there's much I can do about that at this moment. I'm just going to carry on, and hopefully it's recorded perfectly. So then if you are having difficulties right now, you can always rewatch the video later on Medall or YouTube. Okay, perfect. So we'll move on to outcome analysis now. Okay, don't read the words. We're going to discuss it first. There's 2 primary types of outcome analysis. There's something called per protocol analysis, and there's something called intention to treat analysis. Per protocol analysis is an analysis of the study population or of the participants, but only the participants who stuck perfectly to the protocol. They didn't have an extra snack outside. They took their drug or placebo every day at the right time, at the right dose. They didn't forget a single one. Only those participants are included in a per protocol analysis. Everyone else is just chucked off. And okay, I'll explain intention to treat first, and then we'll go into the pros and cons. In an intention to treat analysis, okay, I will go through the run-in period later. I'm just having a look at that. In an intention to treat analysis, every participant is included, regardless of whether they took the drug, whether they didn't, whether they misstepped, or anything. And what happens is the intention to treat analysis, they've done studies on this, and actually, an intention to treat analysis is much more realistic to what happens in a clinical or a GP setting. And it's because not everyone is going to take your drug at the perfect time, on the perfect day, in the perfect dose. Not everyone listens to their GP for every single word they have to say. So an intention to treat analysis, although it'll underestimate the result because you're including people who haven't taken the treatments perfectly, it will be a lot more realistic. Whereas the per protocol analysis will tell you exactly whether the drug is working or not, but it's not as realistic in a clinical setting. And currently, the gold standard method is intention to treat analysis, as was done in this study, as you can see highlighted and there. So if you see only a per protocol analysis in a randomized control trial, that's a big red flag. They should always have that as a secondary analysis. The intention to treat should always be the first thing they do. Okay, moving on, the actual data. So the graphs in a randomized control trial are usually quite standardized. They all have the number of participants on them. So it tells you about dropouts. And again, we'll come to that later on. But they also tell you about p-values and the effects of the intervention. Ironically, they haven't actually given the p-values on this one, but they've measured the changes. These are the graphs for this study for changes in BMI standard deviation score and change in BMI itself. And you can clearly see over the 56 weeks, liraglutide significantly drops both factors. But you can also see after the treatment period, after the 56 weeks, that 26 weeks of follow-up, both the BMI standard deviation score and the BMI itself rose right back up at a faster rate than the placebo. It almost looks like if you carry that on, the lines are going to meet up and everything's going to be the same again. So you can clearly see from here that that this drug will have to be used, if it is used, as a long-term intervention rather than just a short-term, because these people seem to be relapsing to obesity and their BMI seem to be increasing once again. So it just gives you an idea of what the reality of the situation in clinic would look like, or at the GP. Okay, we'll pause again here and I'll look at some of the questions. Explain the run-in period again. I will do that at the end. And why is intention to treat analysis better than per protocol? I'll go through that again in the question section. Okay? It's not information you need now for the next bits of the webinar. So we start off with long-term effects. Again, we've already kind of talked about this. After they stop the drug, their obesity starts to creep back in. And that is a conclusion in itself that you can draw from the study. And that is an analysis you can do of the drug itself. But also, to understand the long-term effects of the drug. This was a whole thing with the COVID vaccine. No one knew about the long-term effects of the drug. And even now, I would say it's not been that long of a period of time. So most studies won't capture the true long-term effects of a drug, which is why you have phase 4 trials, which look at the drug after it's been introduced into the market. So you should always keep a lookout for that. And you could also look at the yellow card scheme from the UK government to see side effects of certain drugs after they've been introduced, to get a more realistic idea of the long-term effects of a drug. So for example, you could do that for liraglutide. I'm sure it's used for other things right now. You could look it up and see whether there are any other long-term effects reported through that system to kind of fill the gaps. And was the trial too short to draw conclusions from? In this case, it doesn't look like it because you can clearly see a massive difference occur in quite a short amount of time. So I think the actual treatment duration was good enough to find the difference. And the follow-up period was also good enough um, to look at that relapse. I would say the follow-up period potentially should have been a bit longer, just looking at the data, because like I said before, they seem to be matching, the lines seem to be matching back up. So it would have been interesting to see if they actually did match up or whether liraglutide did have a more permanent effect in the long term. So again, that's the kind of thing that is important to notice in the data from a randomized control trial and to draw from that. But hopefully you can use these slides eventually as a kind of checklist almost to remind yourself, because you can't remember all of this at once. It comes through practice. So attrition bias. Attrition is participant dropout. And why does that create a bias? Let's say we have a sample of 100 people, for example. Let's say 25 of them have severe hypertension and the other 75 don't. And let's say we've done this exact study. We've given half of them liraglutide and half of them placebo. And let's say for some reason, all the patients with hypertension dropped out of the study. If you just analyze, well, you've completely changed the characteristics of the population, because now your study results are no longer applicable also to patients with hypertension. I hope you're seeing where I'm going with this and why attrition is quite bad, especially if it's a massive number of people that drop out from the study. It changes the baseline characteristics. And if that change leads to a difference in the two groups, the intervention and placebo, then your results are no longer valid, because you don't know if the results have occurred due to your intervention or due to the change in characteristics of the group. So in this case, there was only, I calculated, about a 16% dropout, which isn't too bad. Okay, that's a really good question that someone's just put in the chat there, and I will talk about that in the Q&A section. Good spot. So yeah, 16% in this case of dropouts is not too bad. Anything 25% and above, I would start getting suspicious. And you want to think of why they dropped out. Was it due to side effects, due to the duration of the trial? Was it a difficult protocol, like I mentioned earlier with the SALT study? Actually, I guess I'm answering your question here. Studies should tell you why the participants drop out. If they didn't, that's another red flag there, because it's almost like they're trying to hide something and not be completely transparent about it. So that's something you can definitely comment or pick up on from a randomized control trial. Yeah, and then I was talking about, are the results reliable if many people dropped out? Will it actually be effective in real life if so many people are dropping out or not taking the drug? If 50% of your patients drop out and don't take the drug, what's the point of even introducing the drug into the market? If that makes sense. So moving on from attrition, funding bias, one of the more simple ones. Pharma companies love to see their drugs work. So you always want to look at who's funded a study and what sort of impact they had on the actual experiments. So in this case, let's read through. The trial was designed and overseen by representatives from Novo Nordisk. Normally, they'd want to hire an external group of people to do everything to do with the study. All they should do is just pay for it and have supervisors or people just overseeing. Ideally, studies shouldn't have them involved with data analysis, data collection, and writing of the manuscript. In this case, it's quite interesting. The sponsor, so Novo Nordisk, actually performed the data analysis, which I would say is a bit of a red flag there. I don't know how much I trust that, because that should be completely independent of them, because obviously they want their drug to work. So you don't want them to kind of bias the analysis in any way to make it look like their drug is working. Yeah, but then they also say later on, all the authors had full access to the data and supervised the data analysis and interpreted the data. So that kind of softens the blow, I would say. Yeah, that makes it a bit more legitimate. So moving on, and how generalizable is this? Now you should already be getting an idea of how generalizable It should be from what we were talking about earlier, the inclusion and exclusion criteria, the attrition bias, what type of analysis has been carried out. All those things combined tell you about the generalizability. Where was the study carried out? Like in this one, I told you, it was carried out in 5 different countries. That makes it more realistic to a wider group of participants. How long was the intervention? Can it even be feasibly carried out in a real life setting? And are the results even clinically significant? For example, you can have a tiny change. Let's say the mean BMI due to liraglutide changed from 35 to 33. If you have enough number of people, that tiny change can come up as statistically significant. But will a change in BMI from 35 to 33 actually improve someone's life, actually make a difference to their clinical condition? Probably not. So it's not always the end game to look at statistical significance. You also have to think about the actual results and judge for yourself whether they represent clinical significance. And once again, one study can never be generalized to a whole population. Many different studies have to be carried out in different locations with slightly different formulas or slight tweaks in the method. And then all those studies get combined in a meta-analysis to give a much better, bigger picture idea. And more about that in our next webinar next week. So moving on from this, so the Q&A is after the summary. So that's when I'll be answering your questions. And some of you who've been to my previous webinar to do with lab-based research, critical analysis, will think that the summary slide looks exactly the same as that one. And it pretty much is, because you want to go through a randomized control trial the same way. You want to go systematically through all the bits, go through the study design, through the outcome analysis, and through those miscellaneous sections. And if you don't understand something, Google it. I had to Google the BMI standard deviation score. I had no idea what that was. And always be cynical. Ask yourself, what else could have affected these results? Could these results be not real, and why? What other confounding variables could there be to explain the results? So that's how you start to build really good critical analysis skills. And again, like all research, no research is perfect. So you will find flaws. It's just deciding whether those flaws are bad enough that you don't trust the study or whether they're minor flaws. For example, you might have a minor flaw, as in they've excluded a population, a group of people who make up a standard part of the population. That might be a small thing because it reduces the generalizability of the results, but it doesn't actually affect the conclusions. Whereas something like, let's have a think, what could they have done? That's really red flagged. Let's say they've only done a per protocol analysis and they've not even attempted an intention to treat analysis. Or let's say the funder did everything. The funder collected the data. The funder did the data analysis and statistics and everything. Those are big red flags, which would make you trust the study much less. Okay, so it's all about that judgment. Okay, so I'm going to answer some of the questions now. So if you have any more, just please feel free to put them in the chat at this point. Let's go back to the top. Okay, starting here. What is the difference between clinical significance and statistical significance? So I think I covered that already towards the end of the webinar. Statistical significance can occur even with a tiny little difference, but that tiny little difference might not be clinically relevant, like the BMI example I gave. Then why might a researcher choose a crossover RCT versus a parallel RCT? A crossover RCT needs fewer people because patients can sort of swap the placebo and swap the treatment. So you only need about half the number of people because every patient takes the treatment and placebo first and second after the washout period. And another reason is because every patient takes the placebo and the treatment, their data can be compared before and after, which means the variability in the data is much lower. You have very little biological variability because the same person is being used as their own control. So it's much more powerful in that way. But it also means that patients have to do the study for a longer period of time, which might make them more prone to dropping out. So if I am answering those questions well, please do put it in the chat. Otherwise, I can try and reword. The next one up was, please explain the run-in period again. The run-in period is a length of time before the actual study starts, where you're assessing the patients, giving them a pre-intervention or something like that. So here it was the lifestyle modification. So before they even started the liraglutide and placebo, they would just have the group of participants and give them some lifestyle therapy just to get everyone kind of on the same page, because they included, in this case, they included people who had previously had lifestyle therapy, which they had no idea what kind of lifestyle therapy it was. So this would just get everyone on the same platform. The run-in period is essentially for that, to get everyone on the same level, everyone kind of comfortable with what they need to do and the routine of the trial, essentially. Last two questions. Why is intention to treat analysis I will get to that. Why is intention to treat analysis better than per protocol analysis? It's because intention to treat analysis includes everyone, even if they haven't taken the drug at every day, on every day, or at every given point. And it's better because it's much more reflective of reality. So everyone isn't going to take their drug at the right time every day, or they might miss their dose 1 day or 2 days or 3 days. So an intention to treat analysis accounts for all of that, which gives you a much more realistic idea of how effective the drug will be in a patient population. Whereas a per protocol analysis only looks at people who took their drug every day at the right time, which is just not reality. So it tends to overestimate the effect of the drug. And we talked about whether you expect the study to tell you why people drop out. How do you tell if something is clinically significant? I guess that comes from experience and reading up around the topic, or talking to clinicians, depending on how big the difference is, I guess. Not quite sure on that one. It depends I would take that on a case-by-case basis, and I would read up. That's why I like to also look at the quality of life score, because that gives you an idea of clinical significance. If the BMI, for example, in this case, was changed a lot, but the quality of life didn't really change, then what was the point of giving the treatment? It might have helped their BMI, but it clearly didn't change their quality of life. So something else is going on there. Next one. If we consider only intention to treat instead of per protocol, how can you confirm the drug will work properly or not for the targeted population? So it depends on your targeted population. If you do a per protocol analysis and a lot of people have dropped out from your study, you're not actually analyzing your targeted population. You're analyzing the new population after dropouts, if that makes sense. So you've lost a massive chunk of your target population. So even the per protocol analysis doesn't really tell you about the effectiveness of the drug for a target population, which is why intention to treat is better. I did mention, yes, earlier, if you don't have that many dropouts, then the per protocol analysis will tell you if the drug is good, but it doesn't tell you how well it'll work in people, because people don't always take their drug at the right time, on the right day, or every day, like the doctor tells them to. I'm sure some of you have skipped your dose of painkillers or skipped an antibiotic one day, something like that. And that's what the intention to treat analysis accounts for, that the per protocol doesn't. So yes, per protocol analysis tells you whether drug A treats condition A, but it doesn't tell you that if you give drug A to a patient, whether they'll take it and whether then their condition will improve. It's that intermediate, that patient factor, that is not accounted for by a per protocol analysis. I hope that was helpful. We have plenty of time, so do put in more questions if you'd like. In the meantime, however, do crossover RCTs have blinding as well? Yes, they do. And they absolutely should. Because again, people will do different things if they know they're on a placebo. People just won't take the placebo. Or they might do different things. Does the intervention determine if intention to treat or per protocol analysis is performed? For example, contraceptive pills. From my experience, no. An intention to treat analysis should always be carried out. Ideally, you'd always have both in the randomized control trial, so you're not losing any information. But no, regardless of the intervention, it should be an intention to treat analysis. If you want to explain that a bit further, I can maybe go into a bit more detail. For example, what type of analysis do you think should be done on a randomized control trial of contraceptive pills, and why? And then we can talk about that in a bit more detail. What are the key things to look out for when looking at how a study measures their intervention or outcome? So that was on one of my slides. It's whether their outcome actually represents what they want to answer. So in this case, they measured the BMI, they measured BMI standard deviation, they measured waist-hip ratio, which answers their question of whether liraglutide treats obesity. But let's say they wanted to see whether liraglutide treats hypertension, and they didn't measure blood pressure, then they're not actually answering the question that they're asking. So it's just looking at whether it answers the question that they're asking. In the meantime, while more people type in their questions, we're just going to move on to the post-webinar quiz right now, just to see how much everyone learned. So I'm just going to set that up really quickly. Let's share screen. Okay, and I'm also going to put the voting link in the chat. Please do join up. This will be much easier because now you have a great idea on all the topics we've been talking about. And again, it was a lot of stuff today, so you can always come back and look over this. It should be on YouTube and Medall in the next couple of days. Let's wait a minute longer and then we'll get started. All right, we seem to be at a stable number, so more people can join in later. Let's start. Again, 25 seconds. Okay, let's have a look. Perfect. 4 out of 4. That's what we like to see. Let's move on to the next one. Alrighty, my 4-player. Oh, a 5th is joined. Excellent. Let's begin. Oh, all the questions you guys were asking are the questions I've given away the answers now? Wow, everyone got both my questions right. Great. Love to see it. Okay, stop sharing that. I'm just going to share the slides once again because that'll have the feedback form that you need to fill in to get your certificate. Alrighty, so you have the feedback QR code there. I'm just going to put the link in the chat as well. But if you do have more questions, I will be here for a bit longer, so do post them. I saw the one asking for my email, and I will put that in the chat. There is a link to the feedback form as well. And do join us for the next one, a critical analysis on, well, essentially how to critique a meta-analysis. And that's something I think people struggle quite a lot on because it's so technical, and we'll be going through each of the steps and seeing what are the goods and what are the bads. And the email, anyone here at any of the webinars can message this email if they have questions. It will come to mind, I believe. I tend to monitor that email quite frequently. So I will get back to you very quickly. So I'll be here for a little while longer. I'll leave all this information up. So do ask any more questions if you have any, and please do fill in the feedback form. It really helps us. But otherwise, thank you for attending. And I hope it helped. I hope you learned something, and I hope you'll join us for our next webinar. Alrighty, doesn't look like anyone has any more questions at the moment. If you do have some after, my email is there, which you should be able to see after I log off. But again, thank you for joining. Do fill in the form and come see us, well, me, at the next webinar as well. Have a good evening, guys.